Welcome to video 3. This is Dr. Varela again, and we'll continue our discussion on nitrous oxide with a discussion on its pharmacology and its chemical preparation. Now, nitrous oxide is produced by heating ammonium nitrate crystals, and by heating those ammonium nitrate crystals, the crystals decompose into both nitrous oxide and water. Now, this is chemically scrubbed to remove any impurities such as acids and alkaline products. Nitric oxide is probably one of the most dangerous impurities because it combines with hemoglobin. It can combine with hemoglobin, thus preventing the absorption of oxygen. And once you've got it chemically scrubbed and clean, then it can be compressed into metal cylinders, taking that gas. And when it gets compressed into the metal cylinders, it actually becomes a liquid under those high pressures. These are some of the properties of nitrous oxide. You'll notice that that third bullet point there says marketed as liquid in cylinders under pressure. Like I said, when it's put into cylinders under pressure, it becomes a liquid. And the fourth bullet point there says that it returns to a gaseous state as it's released back out of the cylinder. And so that it really goes from a liquid under high pressure inside the cylinder to a gaseous state when it's released from that high pressure system. Now, nitrous oxide is the least potent of all the anesthetic gases, but you can still reach general anesthesia if you use it in excess. What I mean by that is in large, higher concentrations. Now you'll notice that a safety feature of a lot of nitrous oxide systems is that it won't allow you to administer nitrous oxide at a level higher than 50% or 70% in some cases. And that's really to avoid you replacing oxygen with nitrous oxide. And basically not allowing the patient to breathe in any oxygen at all. So it's really, those safety features are really meant to keep you from essentially suffocating the patient with nitrous oxide gas. Now let's talk about some of the systemic effects of nitrous oxide. In the central nervous system, you'll feel some of the systemic effects are slight depression of sight, hearing, touch, memory, concentration, and pain. And you'll notice that when you have nitrous oxide administered to you, when it starts kicking in, you'll notice that you start to get a little bit of tunnel vision, and you start to not be able to hear as well. Your limbs might start feeling like they're starting to float, and you might be having a hard time remembering things. And all of this stuff are really those systemic effects of the central nervous system that you're experiencing. On the cardiovascular system, no changes in the heart rate or cardiac output except for some slight depression of myocardial contraction. And this is really where the benefit comes from for patients that have anxiety, is that it really kind of decreases the effect of anxiety by decreasing that myocardial contraction. Skeletal muscle, there's no real direct muscle relaxation, and the reproductive system, as we talked about before for female patients, during the first trimester, there has been evidence of some spontaneous abortion and fetal malformations, and fertility is decreased for men with long-term exposure. Now, chronic exposure to high levels of nitrous oxide is capable of producing a sensory neuropathy that can be extremely debilitating. This is usually limited to people who have purposefully abused the drug. So somebody who's constantly huffing nitrous oxide, it can actually damage some of the sensory inputs permanently. And it can really be debilitating. You'll remember from the previous screen that some of the central nervous system effects are slight depression of sight, hearing, touch, and memory, and concentration and pain. And so those things can actually be permanent if chronic use is undertaken. And this really has to do with people who are doing it on purpose, who are abusing the drug. Excuse me. Now, one of the most important things that we'll talk about is that it's so important to have monitoring systems in place to monitor patients while you're using the nitrous oxide. So some of the things that you'll need to do to make sure, and this is going to be important when we talk about documentation of your use of nitrous oxide, it's going to be really important that you get a baseline set of vital signs before you get started, before you use the nitrous oxide. You're going to need to document that the patient gave consent for the use of nitrous oxide. And also you're going to need to record all the vital signs periodically during the procedure, and then have a final set of vital signs after you're finished. So what does that look like practically? So imagine that you're opening a note in Epic, and the first thing that you'll do is that you'll say, patient presented to clinic for extraction of tooth number 15. Patient requested the use of nitrous oxide as a sedative, and patient gave verbal and written consent for the use of nitrous oxide for today's appointment. Vital signs, baseline vital signs were blood pressure was 120/80 with a heart rate of 80. Explained the benefits and risks of the use of nitrous oxide, and this preferably would go before you say that the patient gave verbal and written consent. And then what you would do for that third bullet point where it says vital signs are recorded periodically during the procedure is that you would record every 10 minutes the patient's oxygen saturation, their respiratory rate, and their heart rate. So let's say I started my appointment at 9. We started administration at 9:15. So at 9:25 I would do my next reading, oxygen saturation, heart rate, respiratory rate. And then at I started at 9:15, so at 9:25, and then at 9:35, and at 9:45, and at 9:55, until you're done. And then the last reading would look like administered 100% oxygen for 5 minutes, and then the final, after the 5 minutes of 100% oxygen, this was the final SpO2, which was 100%. This was the final heart rate, and this was the final respiratory rate. So it's really important to not only monitor all of that, but also to document all of that, and that will be required as you use nitrous oxide in the clinic. Excuse me. Now, a couple of the things that you'll need to do for the patient to prepare them for the use of nitrous oxide during the appointment is to ask the patient to make sure that they go use the restroom if necessary, and also review medical history and make sure that there haven't been any changes, and record any preoperative vital signs before starting the nitrous oxide. And this includes blood pressure, heart rate, respiratory rate, and so forth. Also, just kind of a side note that sometimes patients that wear contacts can tend to have a little bit more dry eyes because some of the oxygen and nitrous oxide is actually leaking from the top part of the mask and going right into the eyes, and so that can really dry the patient's eyes out. So let me show you this. I'm going to expand this really quick so that you have an idea of what the form will look like. And this is probably really poor quality, but this is what the form will look like downstairs in the clinic You have the date, the patient's name, their age, what ASA classification, if the patient needed a med consult, and then it will give you an opportunity to show some of your baseline readings for this. It's important to record the time you started nitrous oxide and the percent of nitrous oxide that you use. So that means, did you use 25% nitrous oxide? Did you use 35%? Did you use 50? And so forth. And then post-operative, this is your readings at the end. I think that this is very appropriate. This is great to use. But what I like to do in my Epic notes is to actually record those readings every 10 minutes. It might be a little bit of overkill, but I like to record them every 10 minutes just to make sure that it's understood what the patient's vital signs were. And it really kind of communicates that you're constantly looking at this, and it's not just something that you're looking at the very beginning and at the very end. And then it will require a signature from an attending. Now, technique for administration. So I'm going to go through this verbally with you so that you understand how to do this in the clinic. First, what you're going to do is have the patient sit back in a very comfortable reclined position. Upright position is not recommended except for impressions or radiographs. Then you're going to position, if you have a portable equipment, you're going to position this right behind the patient and out of their line of sight so that you can see the control panels. At the University of Utah, we have a digital system, and this digital system is also located behind the patient, so you won't need to move any equipment around. And we're plumbed for both nitrous oxide and oxygen, so a lot of this won't really need to be taken into account because it's already behind the patient and it's really kind of hidden. The one thing that you will need to do is to make sure that you and your assistant are constantly looking back at both the reservoir bag and at the control panel just to make sure that everything is functioning properly. The nasal hood is then going to be very carefully and cautiously placed on the patient, and you want to start the oxygen flow at 6 liters per minute. You'll place the nasal hood over the patient's nose and remind them to breathe through their nose. Many breathe through the mouth unless you remind them to breathe through the nose, so it's really important to have them breathe through their nose. Now in the back, you'll notice that the nasal hood will have kind of a clamp system back here that will allow you to tighten this around the chair. So you will adjust the ring behind the back of the chair and ask the patient to hold the nasal hood. While you do that, you'll have them hold it in a comfortable position. In other words, this will help you to avoid any problems with comfort for the patient because at some point during the procedure they're going to move and the mask may not move with them, and you'll have a lot of leakage of gas. So you'll want to have them really be part of this process of getting them into a comfortable position for using the nasal hood and using nitrous oxide as you're tightening this behind the chair. And this is kind of what we're talking about. They should be able to have a little bit of movement up and down, left and right. And if there are really a lot of leaks, especially up towards the eyes, then you can use 2x2 to kind of block those and to make sure that you don't have as much of a leak. Adjust the vacuum to inhale and exhale comfortably, and these are on systems that are not already automated. Our systems are already automated, and you can adjust some of those things a little bit, and we'll go over this a little bit more when we actually have our practical experience in the clinic, so that you can kind of understand and have some context for what we're talking about here. Now the patient should be breathing in comfortably and not have any pressure from the nasal mask kind of scrunching up the soft tissues around their nose. Sometimes if the nasal mask is too small, this can kind of push in that nasolabial fold in towards the nose, essentially just pinching off the airway in the nose. So it's really important that you use the appropriate size of nasal hood, and also making sure that the nasal hood has enough flexibility to move around with the patient as the patient moves, and that it's not ratcheted down so tight that it's causing the patient not to be able to breathe through their nose. Now, the next step is to determine the proper flow rate for the patient. Now, you remember that we talked about starting with a 6 liters per minute flow of oxygen for an adult. The patient should be able to take normal breaths and feel as though that volume of air is adequate. And if it's not, then you'll need to adjust it. Now, some patients will require larger flows, such as COPD, endurance sports, heart failure, partial nasal obstruction. So really for COPDs, let's just take them out of the equation and say that we're not going to use this routinely on COPD patients. But for other patients that have maybe some partial nasal obstructions or have a really hard time breathing, you'll want to be able to make sure that they are having adequate airflow. So you may need to increase the flow of air from 3 liters to 6 liters, or maybe a little bit higher. And one of the best things to do that will help you to understand whether or not the patient is breathing enough is to ask them, can you breathe normally? And you'll want to, if they say no, then you'll want to increase the flow at 1 liter per minute increments until the patient says that they can breathe very comfortably. And you may need to use higher flow rates at the beginning, especially if this is the patient's first time. They may not be familiar with the process. Now, as I said before, it's going to be really, really important for you or your assistant or whoever else that you have that's trained in the room to make sure that you're looking at the control panel and watching the reservoir bag. Now, the reservoir bag is that green bladder, the green rubber bladder, and it should be completely inflated. And when it's completely inflated, you'll notice that as the patient breathes in or out, that's reflected in the expansion and contraction of the green bladder. So as the patient breathes in, the bladder collapses a little bit, and as they breathe out, the bladder inflates a little bit. You should be able to see this. The thing we want to avoid is to have a situation where the patient, where that bladder is completely empty, it's completely collapsed. It's like an unblown up balloon. Because if that's the case, the gases won't mix and the patient won't be able to breathe. So it's important that you use the button on the control panel that says O2 flush, oxygen flush. The oxygen flush will fill that green bladder and will expand it so that the patient is able to breathe in and out. Now, a couple of things will happen if you don't do this. Number one, the patient won't be able to breathe very well. And number two, if you have nitrous oxide going, they're not going to be able to feel the effects because it's not mixing with the oxygen and it's not being breathed in. So you need to make sure that that green bladder is completely inflated. Now, occasionally you need to monitor this because occasionally that green bladder will collapse completely because the patient has taken in a couple of deep breaths and just completely evacuated all of the gases that are in that green bladder. And so it will be completely collapsed. And if this is the case, you or your assistant need to make sure that you press the oxygen flush button to allow oxygen to refill that bladder and blow it back up. Now, if the bag is overly inflated, one of two things happens. Either the minute volume is too great, or there's a hose that's kinked or occluded, and the patient doesn't have the ability to breathe comfortably. So it's really important that you watch. And one of the things that happens here is that the hoses, as you'll notice, come back behind the patient's head, and then they come behind the chair. So let's go back to this picture. They come behind the chair. Sometimes these hoses are really long and they lay on the ground, and sometimes the provider or the assistant will roll over the hoses, either partially or completely occluding them. And so it's really important that you watch for this, because if that hose is occluded or kinked, the patient's not going to be able to breathe. So be very, very careful with this. Now, you have the patient properly seated. You've adjusted the patient's mask so that that it fits comfortably. You've adjusted the flow of gases so that the patient is able to breathe. Now it's time to titrate the nitrous oxide. And there's really two methods of administration. One, constant liter flow. So the total liter flow of gases per minute kept constant, and the percentage of nitrous oxide is adjusted. And our units have a mixing button, so you can tell the system exactly how much nitrous oxide you want, and it automatically will adjust the nitrous oxide and oxygen balances to reflect that percentage. What that means is, if you say, let's say that you have them on 6 liters total gas flow, and you start out with 100% of oxygen, and you turn up the nitrous oxide to 25%, then it will take 25% of that 6 liters and give you nitrous oxide. So 25% of the 6 liters will be represented by nitrous oxide gas, and the other 75% will be represented by oxygen. And this does this automatically. The second method is the constant oxygen flow, and this means that oxygen flow is kept constant and the volume of the nitrous oxide is adjusted. So this is represented in this picture on the screen, and this is a situation where you can control the nitrous oxide and control the oxygen separately. Okay, this is where it's not done automatically, but you have to control everything separately. And this is really seen in a lot of those portable systems, which really we don't have here. But at some point in your career, you will be using one of these portable systems. So it's really important for you to know that with these constant oxygen flow systems, you basically have to titrate the levels of each gas manually, because the equipment's not going to do it on its own. This is really not the ideal situation, just because their mistakes are really easy to make. And the common misconception is that the flow of nitrogen oxide equals the percentage of gas. So in other words, that 2 liters per minute is actually 20%, and that's not necessarily the case. Just to be very clear, the units that we have here at the school do a lot of the gas mixing on their own, and a lot of the other systems that are manual systems require you to know how to mix the gases properly. And so what we'll do is what I'll do is that I will actually find one of these systems, and I'll make a video on how to use these systems properly. For right now, your exam will not cover this particular system, the manual system. It will really cover the system that we use here at the clinic. But I will provide you with a video that will give you a little bit of insight into what we're talking about here with this constant oxygen flow system and how these things are mixed. Now that we've started administering the nitrous oxide, it's important to make sure that you're constantly monitoring the patient. You'll want to start at 20% nitrous oxide and make sure that you're looking for signs and symptoms of sedation. And at the end of about a minute or a minute and a half, you ask the patient how they're feeling. It's an open-ended question, so that they can give you kind of a description of what they're feeling, what they're sensing. And at 20%, there's usually very little effect. So you'll probably have to bump it up to a little bit higher, to like 30% or 35%, and make sure that the patient's legs are not crossed. Um, and patients rarely move when they're sedated, and there's a lack of circulation. So if the patient's legs are crossed, the blood's not going to be flowing properly. And remember, in our conversation in the first video when we talked about the effects of this nitrous oxide really depend on how well the patient's blood is being pumped throughout the body, and crossing your legs really kind of slows that process down. And you'll want to continue the titration of nitrous oxide as you observe the patient according to their need. So about every minute, minute and a half as you're starting to titrate, you can increase the nitrous oxide percentage by 5 to 10%. So you'll start out with 20, maybe go up to 25 or 30. And then if that's not sufficient for the patient and they're not feeling any change, then you'll want to go up to 35. Until you see that the proper sedation is starting to appear, the patient's starting to feel a little bit tingly, they're starting to feel kind of that warm floating feeling, patient's starting to feel more relaxed and comfortable. Now, a couple of things, the patient may be starting to feel some lightheadedness. It's usually the first effect, and some people say that they feel dizzy. You need to ask them if this makes them feel uncomfortable, and tell the patient that this is really, really kind of a normal process as they're passing through nitrous oxide, and that it will kind of go away as time goes on. Now, this usually develops at the stage that it's clinically it's inadequate for management of most patients. So in other words, when a patient starts to feel lightheadedness and they say that they're feeling dizzy and they're feeling uncomfortable, at this point it's probably a good idea to back off the nitrous oxide, and nitrous oxide is probably not going to be a good option for this patient. The patient may also start to experience some tingling or paresthesia of the arms, legs, or mouth, and the symptoms develop at levels that are still inadequate to permit the ideal management. So if this is starting to occur, you may want, and it starts to get worse as you increase, you may want to back off of this and basically ask the patient if they want to continue, because it's only going to get worse. And if it's getting worse at lower levels, or levels that are inadequate to permit the ideal management of a fearful patient, then this is probably, nitrous oxide is probably not a good intervention for them. But if you ask the patient and they feel warm, floating, all of this heaviness, like their arms and hands are starting to float and this heaviness is kind of going away, then you're at the ideal level and the patient's relaxed and comfortable and you're there. And so make sure that you ask the patient as you're starting nitrous oxide titration how they're feeling, what they're perceiving, if they're feeling kind of a warm feeling, if they're starting to laugh, if they feel comfortable and relaxed, then that's a really good level to stop, and you don't need to go any higher with the nitrous oxide. So these are signs and symptoms of nitrous oxide sedation, and which phases you actually experience them in. Early to ideal sedation, heavier sedation, slight oversedation, and oversedation. So these are the symptoms that you'll feel during early to ideal sedation. You may feel some lightheadedness, tingling, a wave of warmth, feeling of vibration throughout your body, numbness of the hands and feet, numbness of soft tissues of the oral cavity. You might start feeling euphoric and feeling of lightness or heaviness of the extremities, and you might feel some analgesia. You'll notice that for some patients you might see some changes in blood pressure, and heart rate is slightly elevated early on in the procedure, and then it returns to baseline values. Respirations are normal and smooth. You've got some peripheral vasodilation, flushing of extremities and face, and decrease in muscle tone as the anxiety decreases. For heavier sedation or slight oversedation, you might feel like the hearing, especially of distant sounds, becomes more acute. Visual images become more confused, so patterns on the ceiling begin to move. Sleepiness, Sweating increases, laughing, crying, dreaming, nausea. Um, you might notice signs of increased movement, increased heart rate and blood pressure, increased rate of respiration, and increased sweating, possibly some crying as well. And over sedation, the patient will definitely feel nausea, and you might see them vomit or lose consciousness. And this is when you know that they're getting way too much nitrous oxide. So I mentioned in the previous slide, and I don't want to leave you with any confusion that maybe laughter would be a good sign, but according to this table, laughing and crying is a sign of heavy sedation or slight oversedation. So really, the section that you want to stay in with respect to signs and symptoms of nitrous oxide sedation is that early to ideal sedation stage, where you may feel some lightheadedness that will pass, tingling of the hands and feet. You might have a wave of warmth and a feeling of vibration throughout the body, numbness in your hands and feet, numbness of the soft tissues of the oral cavity, feeling of euphoria, feeling of lightness or heaviness in the extremities, and analgesia. And then you'll have these clinical signs that you will be able to observe to the right. As you get to a point where you're doing a little bit heavier sedation, a slight oversedation, or even step 3 oversedation, the patient will be feeling these symptoms as seen on the screen, and you'll be seeing the appropriate signs. And really, you want to stay out of section 2 and 3. You really want to just, you're going to live in this area of section 1 of early to ideal sedation. So if you start having patients that are, having visual images and becoming confused, sleepiness, laughing, crying, dreaming, nausea, you really are over-sedating them, and you want to back off of the nitrous oxide for sure. The most important thing, aside from having monitoring equipment, is making sure that you're observing and monitoring the patient. Now, a few patients might begin to perspire really heavily and feel uncomfortable, so you need to make sure that you decrease the nitrous oxide by 5% in an attempt to decrease perspiration without altering the level of sedation. And this is a technique for oversedation. You decrease it by 5%. Now, a patient being sedated for the first time, it's more difficult to gauge the proper level of sedation because it's the first time that you're doing it on them. And so it's really important to watch these patients and get an idea of how they're reacting to this sedation. And as the sedation increases, the patient's responses will become slower. There might be an increase in lag time between questions and answers. And that indicates really that that you're more near the ideal level. So this is a good place to stop. We have a couple more. Actually, let's plow forward. We have 1, 2, 3, 4, 5, 6 more slides, and then we'll be done. So then once you've titrated the patient to the right level of nitrous oxide sedation, and they're kind of in that sweet spot of this section 1, early to ideal sedation, it's time to begin the dental treatment. And really, the only way of determining with absolute accuracy whether the proper sedative level has been achieved is to begin the planned treatment and observe the patient's response. So go ahead and give them their local anesthetic, give them the injections, and see how they respond. If before nitrous oxide they would have responded by getting really nervous, putting their hands up, and now with nitrous oxide they're not doing those things, they're feeling really relaxed, they're not fighting or combative, then the nitrous oxide is working. And really, that's the only way to determine whether or not it's working, is to really just kind of get into the dental treatment and see how the patient responds. And it's not really usual for patients to make like sudden movements like grabbing their face or grabbing your hand or anything like that, especially when you're doing a traumatic procedure. If there is disruptive behavior that is occurring, you want to stop and increase the percentage of nitrous oxide by about 5%. Remember that those are the increments that we need to increase and decrease, and it usually helps to eliminate the problem. If after the first 5% increase it's not going away, do not keep increasing it higher and higher and higher and higher. You need to stop and reevaluate, ask the patient if this is the nitrous oxide is actually helping. Because can you increase it higher than 5%? Yes. Should you? Depends on where you are. If you're only at 20%, sure, you can go up another 5%, maybe another 10%. But if you're already up to 35%, and the patient is already having some disruptive behavior, we really need to ask ourselves if this nitrous oxide is actually helping the situation. But once pain control is established, you usually have no problems proceeding with the procedure. Now you want to make sure that you monitor the patient and the equipment at the same time. You're constantly monitoring it, which is why I usually like to do my documentation every 10 minutes or so to make sure that I'm constantly checking those two things, making sure that I'm looking at the patient, making sure that the patient is doing okay, and then also looking at the equipment that I'm using. Now, a prime benefit of inhalation sedation is the ability to tailor that sedation to the needs of the patient. So as the treatment proceeds and maybe the anxiety level increases, the patient might become overly sedated. So it's really important that you have the ability to decrease the flow of nitrous oxide by 5 to 10% within 30 to 60 seconds so that you can actually visualize whether the patient is responding better or not. The patients should be able to respond to questions, and any lack of responses indicates that the treatment with using nitrous oxide might need to be backed off or terminated completely. So usually, if the patient is not responding to your questions, then you have them overly sedated, and you need to back off by 5% increments, 5 to 10% increments, and usually that will bring them back into a normal response. It's really important that you know that the titration stage of nitrous oxide sedation is probably one of the most important stages of the whole situation, because this is where you see whether or not you're over sedating the patient or if you're kind of at that ideal stage. Now, at the completion of your treatment, the way that you terminate nitrous oxide is by decreasing it in 5% increments, 5% to 10% increments until the nitrous oxide flow is 0 and the oxygen is at 100%. And you want to leave the patient at oxygen on 100% oxygen for at least 5 minutes. And the longer period of longer than 5 minutes may be needed if the procedure was longer. And the signs and symptoms of the sedation persist. So if the patient's still feeling some of those side effects of nitrous oxide sedation after 5 minutes, then you might want to leave them on oxygen for 5 minutes or for a little bit longer. And just keep communication with the patient. Ask them to make sure how they're doing as they're on that 100% oxygen. Make sure that you have them on 100% oxygen and that you have not mistakenly increased the dosage of nitrous oxide. You have to be very vigilant. Now, nitrous oxide is not titrated out of the patient like at the start of the procedure. You can basically go to 100% oxygen in a very short amount of time. Again, maybe slowly going from, for example, 35% oxygen or 35% nitrous oxide to 0% nitrous oxide, slowly in 5% to 10% increments until the patient is at 100% oxygen, and you leave them there for 5 minutes. Do not leave the room. That is a big no-no. You do not leave that patient in the room by themselves while they're on nitrous oxide or while they're on this termination of nitrous oxide where they're on oxygen, 100% oxygen for 5 minutes. A patient who is on nitrous oxide or who is on oxygen should never be left alone in the room, period. Now, once the patient has kind of come back to normal and they've been on oxygen for at least 5 minutes, you need to make sure that the patient is feeling well and that they are not having any additional side effects from the nitrous oxide. And as long as they have come back to normal, then it's okay to turn off the nitrous oxide oxygen system and then have the patient very slowly get up out of the chair very slowly, maybe starting in a sitting position with their feet on the ground. Have them pump their legs a little bit so that some of that blood will rush back up to their head before they get up. Now, when do you turn off the nitrogen or the nitrous oxide? And it's going to vary for each patient and for each provider and for each procedure that you're doing. Typically, I like to start turning it off. For example, if I'm doing an extraction, if I just barely took the tooth out, if the tooth has been elevated and removed, and I'm ready to start irrigating, then at that point I will turn down the nitrous oxide and put them on 100% oxygen at that point while I'm still irrigating the extraction site, putting a 2x2 there, getting hemostasis, or maybe even placing sutures. And then after 5 minutes, I'll talk to the patient, ask them how they're feeling, and if they're feeling okay, then we'll take them off of the nitrous oxide. Another example could be if you're doing a restoration on a patient. If you're at the point where you've just finished placing the restoration and you're about to get ready to take the rubber dam out, then at that point that would be a good time to turn off the nitrous oxide, put them on 100% oxygen for 5 minutes while you take the rubber dam out, while you check the occlusion, while you are polishing the restoration and so forth, so that by the time that you're finished with everything, the patient has already done their 100% oxygen for 5 minutes, and they're ready to get going with the rest of their day. But it really will depend on each patient. Discharging the patient. The patient is discharged and allowed to resume normal activities without any restrictions. Now, for this reason, the dentist must be absolutely certain that recovery is complete before considering discharge. So do not let the patient go if they're still having lightheadedness, okay? You need to keep them on the oxygen until all those symptoms go away, and make sure that you don't send the patient away when they're still feeling lightheaded or dizzy. Now, the response to questioning is a primary determinant of recovery from sedation. So if you're asking your patient a question and they're not responding, or they're maybe taking a little while to respond, they need to still be on 100% oxygen so that they can flush all of the nitrous oxide gas from their system. Some objective tests that you can do is take your vital signs. Neurological tests make sure that you can ask the patient to touch the tip of their nose with their little finger. And this is really useful for your medical legal responsibility. So if you are asking the patient to touch the tip of the nose with a little finger, and they are able to do it, document that. And document that you took vital signs, that the patient was awake, alert, and aware before you discharged them. Make sure that you clean the equipment. The nasal hoods have been shown to be contaminated with multiple human pathogens capable of transmission from one patient to another. Typically, the nasal hoods are disposable, so throw them away after each patient. Sterilization, any parts that might be sterilizable need to be washed with warm soap and water, and then immersed in glutaraldehyde solution for 10 minutes, and then rinse with tap water. Tubing, the reservoir bags and nasal hoods, again, with patients with HIV or other communicable diseases, those are disposable, so you will dispose the tubing, reservoir, and nasal hoods for those patients. So finally, a summary of clinical signs and symptoms of oversedation. I can't stress this enough. Is so important to understand, because you can really do a lot of damage if you oversedate a patient. So really, what I want you to take away from this is that you are in a very unique position as a dentist, as an oral health care provider, to be able to provide a form of sedation that you don't necessarily need to be in an OR for. Okay, you can provide this in office, and a little bit of danger is presented in that, because you need to be able to have monitoring equipment in place and safety protocols in place to make sure that the patient is handling this sedation technique well, and that you are able to rescue the patient from any situations. So for example, if you have a patient that's on nitrous oxide sedation, you need to have your monitoring equipment, making sure that they're getting plenty of oxygen with their SpO2 stat, checking that every 10 minutes. And you need to be able to make sure that your equipment is functioning properly. If the equipment is functioning properly, then you'll be able to titrate. If it's not functioning properly, then you can't titrate, and the patient may have an adverse event. So I thank you very much for your attention and your patience. Please read over the slides. Some of the things that I've said have not been covered in the some of the things that that are on the slides have not been something that has necessarily been said, and some of the things that I've said have not been covered on the slides. So please make sure that you go over these videos very carefully and prepare for the exam. Thank you very much.